I will be presenting some case studies today looking at laminated mural thrombus. The cases I'm showing are apical ones, but as I'll discuss, that can also occur in other regions as well, other than the apex. When we think about thrombus and thrombosis, the formation of clots, the main one that comes to mind is actually Virchow's triad, which is looking at normally the presence of a number of factors leading to the likelihood of the formation of a thrombus. These really are looking at stasis, so areas of low flow, and so normally going to need a low ejection for that and an akinetic area. Also looking at degree of the actual underlying irritation, inflammation of the actual myocardium, and some reason for some additional hypercoagulability as well. It's less common to actually see thrombus formation in Takotsubo and dilated cardiomyopathy, primarily because they don't necessarily have the same degree of subendocardial injury in comparison. This is just a very extreme example here of an image I found online, which is just showing a completely clotted left ventricle as you look up from the subcostal view here, where the heart really just doesn't move and it's just a massive thrombus. There's a number of points to sort of be aware of. So thrombus formation can occur within 24 hours. Some centers suggest around 72 hours tends to be a relative peak when more likely we'll see. Up to a couple of weeks post-infarct, but it can actually even be longer than this. Some suggest as well that mural thrombus may actually have a positive role rather than just being a completely negative thing. I mean, it's a normal phenomena. The body actually produces this clot for good reason, potentially. One, it may offer actual some mechanical support, and so it may limit LV rupture, so it may have a helpful value there. It may also serve a role in limiting the infarct expansion. There's a question on whether it actually helps restore geometry and also the wall thickness there and decreasing the wall stress for that reason. However, the only problem with this is that often the wall expansion is already occurring before the thrombus formation actually occurs. Other points included are the fact that I'm not going to give you exact numbers in terms of it because the numbers you read are so variable in terms of relative reported incidence, because it really comes down to how you look at it, and the studies vary markedly in what they actually say. In modern times, it seems to be actually less though because of the fact of more aggressive anticoagulation, improved remodeling earlier on, and also acute intervention. So commonly infarcts are smaller, and we actually see less apical aneurysms than we used to years ago. The other point, of course, to note is the fact that with 2D standard echo, the fact that thrombi are commonly missed relative to LV opacification, but even with LV opacification, it's still markedly lower than CMR. The cardiac MRI is much more sensitive in detecting. There's still a question, though, on even when you detect them, how relevant they actually are in the fact that you're picking up these tiny ones with CMR. When we consider the various echo points, there are a number of things we look and think about. We need to sort of characterise how big it is. Then we're generally going to give dimensions and what to say where we've got that from. The degree of mobility of it. Is it fixed? Is it mobile? What shape? What size of attachment zone? Is it single? Is it multiple? Is there actually an active free edge? Because the fact this is a layering process, and the fact that it's the top active free edge, it often is the part that's more likely to break off and actually form a active thrombus in transit in comparison. We also need to describe the underlying regional walls, whether it's aneurysmal, whether it's just expanded, and also how bad is the LV. We also look at other things such as the presence of spontaneous echo contrast. We also have to be aware, though, that even though greater mobility is more likely associated with embolic episodes, one study did show that 40% occurred in patients with relative non-protuberant and non-mobile thrombi. Ideally, we also want to look at the thrombus from different windows to reduce the potential that what we're actually looking at is actually an artifact. We also need to always sort of include in our report the description. If we say there is no apical mural thrombus detected, we have to say with what degree of sensitivity we really believe that actually is. We also have to forget that other walls other than the apex can be affected, and also the RV, so infarcts in any wall can produce thrombus. The other point is the fact that we have to have a very high level of suspicions in the right patients and actively exclude them because of the fact that standard imaging planes may not actually show it. So part of the low sensitivity of echo is the fact that people just may not have looked hard enough, maybe one factor. We also have to say that's why we have to really consider using off-imaging plane to really reduce our depth, use the highest frequency possible. We also want to put the dynamic range up and maximize that frequency because we want to really try and differentiate any tissue we see there as well as is a myocardium or is it thrombus. And so, as I said before, thrombi are often missed on echo relative to LV opacification, but even that is much poorer than cardiac MRI in comparison. Here's just an example of LV opacification contrast. For those unfamiliar with the view, we've got a 4-chamber view here, and the one on the left is just a larger one where I'm just zooming up upon the right apex here. I mean the left ventricular apex on the right-hand image. And we can see a black portion actually over down here, and this is actually was a LV thrombus with this patient on that lateral apical wall there. If we're looking actually in short axis as well, we can actually see the right one will start there now. This same region over here is actually the thrombus formation in this case. So when you look at the data, there's always going to be various management algorithms and like this one's from the AHA from 2022. It does suggest various things, but there's still a lot of questions on it in terms of how aggressively should you look for them, how aggressively should you treat them, what should you actually treat them with, how often should you reevaluate them, and so there's actually just as many questions as there are answers in this current time. The first case I'm going to present was a patient that actually had an anterior STEMI overseas, and we saw him about a month later. It was attempted treatment, there was no intervention really available there. Thrombolytics were tried, but really ended up with a large infarct. On return, he did one angiogram, did show triple vessel disease there, and he ended up going to CABG after that. When you actually do look at his thrombus, so there is actually some degree of restoration of the wall thickness and the cavity shape by the actual thrombus. Today I'd like to show a case of an apical mural thrombus. In this first view, when we look at it, we can see the posterior wall here, the infralateral wall moves just fine, and the anteroseptum also looks fine there. But as we look up towards the apex, we can see a relative akinetic portion as we head towards the apex there. When I look in the short axis view, initially close to the mid-level, nothing too obvious jumping out, but as we come down we start seeing a region that looks thicker. The differential diagnosis of course is apical hypertrophic cardiomyopathy, but as we see in areas of akinesis, we're always going to be more concerned about potential thrombus formation. And so in these various short axis views, you can see relative cavity obliteration looks like as we get down towards the very distal apex there. And again, a different echo density to the surrounding tissue that we have going around there. And again, just another short axis there, just showing that region of interest. When we go to the 4-chamber view, it very clearly shows this nice region here of akinesia. And also we have a degree of thickening that you wouldn't be expecting with that degree of akinesia of the actual apex there. Again, when we look at the 4-chamber view a bit closer up, we see that thickening going along there particularly. And again, relative different echo density when we actually look at it. Of note, there doesn't appear to be a relative active free edge that can be seen. It's the free edge that tends to cause a problem in terms of clot coming off and causing thrombus heading to some other part of the body. We go into a 2-chamber view, similarly as well. Quite a thick region really when you think the endocardium's up there. And again in the apical long axis view, seeing very nicely and clearly there. Just zooming up on a little bit more detail, you can see this whole very thick region there. And swinging around to a different view there, 2-chamber and then back to a 4-chamber in zoom. And when you look there, it's at least approximately a centimetre or more thick, which tells you it's probably built up over time. And as I say, when you look closely at it, though, there's definitely no sign of that active, fresh component on the edge there going on. As I say, whenever you have a region of akinesia, it always just makes you contemplate whether there could be thrombus in that region, and this example is a very nice example of an established thrombus. The next case to have is another patient in his 40s that did have a very high family early cardiac death history, and so he also had a CT calcium score a few months before this was done, which was around 700 for someone in his 40s, quite high. When you look in his parasternal long axis, the septum you can see down here really isn't moving particularly. And this appearance here, you could look and think, oh, what's that? At the very least, you think it's probably spontaneous echo contrast. And looking in the short axis, again, you can see that anterior wall just doesn't look great. And just coming down, as you get towards the apex, you definitely start seeing an extra mass there. And then further down towards the tip of the apex, you can see it looks quite pronounced. This view here is just a bit of a longer view, as it's sweeping down through from those walls down, so it's just a longer clip in short axis going towards the apex. Here we can see the 4-chamber view. You can see the function's quite impaired there. Its size was also moderately up as well. And even looking at the anterolateral wall, the top there towards the apex looks questionable. And again, it looks quite dubious as you look a bit more closely at it. As you actually come up closer and tilt, then you start seeing this apical mass coming into view. And then again a further tilt, which is quite off axis relative to the standard 4-chamber, but you often do have to follow them as much as you can. Going over towards a 2-chamber view, and again towards the distal apex, you definitely can see something there. There's also a band traversing across the tip of the left ventricle there too. Here's close up, you can just see those bands, which sometimes can be confusing with people who do have quite trabecular apexes. But as you look a bit more closely at the distal apex, it becomes quite obvious as you really open up that distal apex, that significant formation in there. And then just a slight rotation around, and around a bit more. Now towards the apical long axis. And again, as we zoom up again towards that apex, it becomes quite obvious in that off-angled imaging. And then I just want to highlight here that when you look at the 2-chamber, in some ways it would be very easy to miss it if you were not looking for it deliberately. I have one last case here as well, just showing a more protuberant actual mass in comparison. Very obvious in this case exactly where the mass is. And so when you look quite close, you say, yes, it's quite a large, unquestionable one there. You can see the underlying akinesis underneath it. Just rotating around a little bit there. It's looking quite obvious there. In the 2-chamber view, it's quite an expanded looking apex underlying the actual thrombus. And in the apical long axis, again, looking very nice in terms of how protuberant that actually is. And so, just zooming up a little bit more closely at it. And as I say, again, there's no particular active free edge. It does help restore the geometry a little bit, but again, it's not particularly normal geometry by any means. And into 2-chamber, and just one last view, looking again at that apical long axis view.